To Lancaster, Morecambe Bay, CCG. Just a few introductory remarks from me, if I may. We've tried in recent meetings to try and ensure that we make ourselves and the meeting more accessible to members of the public. That is in terms of locations, in terms of public transport and so on. And so that also we arranged a room in such a way that people can see who we are and what we're saying. I hope we don't get pilloried for this today, but that's a joke, sort of. But generally speaking, we are doing our best to make it easier for members of the public to understand what's going on in our meetings. We'll try not to use acronyms. ICS is one that we'll slip into, Integrated Care System, but we will do our best not to do that. In line with our former meeting that we held in Leyland, we have given the opportunity for any members of the public for half an hour before the meeting to talk to the three of us here, basically in the middle, to have any questions answered about the agenda and the reports. And so that rather than wait 2 hours and not be quite sure what's going on, there is the opportunity for people to ask questions and so on. And there will be an opportunity at the end of the meeting, a short space of time for questions, which will be about the agenda, not about any other general issues. Just to remind everyone, this is a meeting of the joint CCGs, which is taking place in public. It is not a public meeting where that's dealt with in quite a different way, with much more involvement directly with members of the public. So hopefully we are making ourselves more accessible. We're open to any other suggestions that members of the public or indeed members of the committee have about how we can better ensure that what we are doing is understood by the public at large. As part of that also, you'll probably see there are cameras around. This is being, I won't use the right technology here because I'm elderly. So it's being live streamed, so there will be members of the public who are not in the room also who will be able to see and hear what is going on in the meeting. So I think that's on YouTube through our website, if I've got that correct.
That's right.
Yeah. Okay, so we'll then move on to the meeting itself. I've received we will introduce people after I've read out the apologies, by the way, and we'll go around the room so that everybody knows who everybody else is. We've had a number of apologies from Gora Bangi, David Bonson, Debbie Corcoran, Samutra Mukherjee, Catherine Fairclough, Angie Ridgewell, Dawn Roberts, Louise Taylor, Lawrence Conway, Gary Hall, Dean Langton, Sybil Taylor, Clive Unit, and Paul Kingham. Are there any other apologies?
Apologies from Jerry Hawkins.
From Jerry. Thank you. So, by way of introduction, my name's Phil Watson. I'm the independent chair of the joint committee. I am not a clinician and I'm not associated with any of the health authorities that are part of this programme. We'll go around this way.
Thanks, Chair. I'm Andrew Bennett. I work for Healthier Lancashire and South Cumbria. That's the name we give to the integrated care system. My lead role is for commissioning.
Sorry about that. Hello, I'm Elaine Johnston. I'm here in my capacity as Chair of the Commissioning Policy Development and Implementation Group to present item 7.
Hi, I'm Rebecca Higgs. I'm the Policy Development Manager at Midlands and Lancashire Commissioning Support Unit.
Hi, I'm Doug Soper. I'm a lay member at West Lancashire CCG.
Good afternoon, Dennis Streets, the Chief Officer of Greater Preston and Chorley South Ribble CCGs.
Good afternoon, I'm Gaynor Jones. I'm Executive Assistant to Gary Raphael and Andrew Bennett at the Integrated Care System.
I'm Jeff Jolliffe, I'm the GP Chair of Morecambe Bay CCG.
Hi, I'm Jane Cass. I'm Performance and Planning Lead for Healthier Lancashire and South Cumbria.
Hello, I'm Carl Ashford. I'm Strategy Policy Lead with the Healthier Lancashire and South Cumbria.
Hi, I'm Mary Dowling. I'm Chair of Fires and Wires CCG.
Good afternoon, I'm Roy Fisher, I'm Chair of Blackpool
Hello, my name is Mark Hilton, I'm Chief Officer at Lancashire CCG.
Hello, Dominic Harrison, Director of Public Health. Chief Executive of Blackburn and Darwen Council.
And I'm Graham Burgess, I'm Chair Blackburn and Darwen CCG, and it is working.
I'm Gary Raphael, I'm the Finance Lead for Healthy Lancashire and South Cumbria.
Good afternoon, Sue Stevenson representing the Health Watch Collaborative for Lancashire and South Cumbria.
Hello, my name is Neil Greaves, I'm the Comms and Engagement Lead for Healthier Lancashire and South Cumbria.
Hi, I'm Anthony Garden, I'm Director of Planning and Performance at Morecambe Bay CCG. I'm here for Jerry Hawker.
Hello, I'm Gemma Stannion. I'm the Programme Director for the Acute and Specialised Portfolio in Lancashire and South Cumbria Integrated Care System, here to talk about stroke.
Hi, I'm Claire Kindness-Cartwright, one of the Senior Programme Managers on the Acute and Specialised Portfolio, talking about stroke.
I'm Jeff O'Donoghue, lay member for Chorley and South Ribble CCG.
I'm Amanda Doyle, I'm Chief Officer of the Fylde Coast CCGs, and I am the lead for the Integrated Care System.
Okay, thank you very much. Item 3, are there any declarations of interest? Just to remind you, either do so now, or if it occurs to you during the meeting, will you indicate at that time? So are there any declarations of interest to declare now? No, thank you very much. We move on to the minutes of the meeting held on the 4th of October. I'll go through them page, but the pages aren't actually numbered, but I'll pretend they are. Page 1, page...
Chairman, can I just raise a general point on the declarations of interest? I don't think it's particularly important with regard to the last meeting, but it may well be in future meetings. Can we be clear, if there's a declaration of interest, exactly what the interest is?
Yes.
In what item it refers to, or items, and what action, as chairman, you're taking, whether the person's going to be excluded, allowed to speak, or whatever. Because it's not clear on last month's with regard to the one from Bangui.
Okay, yes, thank you. We'll do that. That's a good idea. Thank you. So page 2, page 3, page 4, page 5. That's item 7, by the way, on page 5 and 8. Page 6, page 7. I think that's it. So there are no corrections or comments other than Doug's general point, which we can perhaps deal with in terms of the minutes to make a specific reference, if that meets with your approval, Doug. So subject to that.
Yeah, I'm more worried about future meetings if
Yes,
we get into something that's
correct.
more contentious, to be honest.
Okay. Thank you very much. So are those agreed? Thank you. We have the action matrix, which refers to an item that's outstanding, but it's on the agenda at 7A. Any items of other business that may be raised later in the meeting? Dominic.
Yes, Chair, could I just like to raise an item for 5 minutes just on population health and healthy weight management?
Okay, well, subject to us not running out of time, as I think we've already agreed, the committee are happy that we accept that short contribution from Dominic. Thank you very much. So, we move on to the main items on the agenda now. At item 7, we have improving population health and 2 reports, well, 7 and 8, but 7 is in 2 sections. As last time, the proposal is that Elaine will give a short introduction to each of the items under 7A and B, and then there'll be an opportunity for discussion and then a decision made. So if that's okay, Elaine, thank you.
Thank you, Chair. As last time, I'll begin just by giving a little bit of context for this work. So I've said when I introduced myself that I'm here as Chair of the Commissioning Policy Development and Implementation Group. That group's been in existence since April 2017 and was established to enable the 8 CCGs across Lancashire and South Cumbria to address areas where commissioning policies were required to ensure that we made the most evidence-based and of NHS resources and did so equitably across the 2 examples of our work. So I'd like to move straight on to the paper that you have, the briefing paper that's before you, and talk just in general, as we've spoken before, about the process that we go through to develop policies, which is listed under section 2 of the paper. Just to say that actually we start by understanding the clinical evidence base for the area that we're looking at. We do that by asking a specialist colleague, often a public health colleague, to review the evidence base for us and to help us identify criteria for how we commission. We will then take those out to the clinical body within Lancashire and South Cumbria for clinical engagement as a first stage. The policy group will then review what comes back from there, and then we will move from that stage into a stage of public engagement. And as we talked last month, the type and nature of that engagement can vary according to how different the policy might be from anything that's been around in the past. So it will vary from a short 4 weeks, largely website-based consultation process for things where there's minimal change, to a much more extensive 12-week programme that could even involve things like focus groups and public meetings. And you'll see examples of 2 different things today. So we go through that process, we then take on board everything that comes back, seek any additional advice that we need to seek before finalising the policy. And along the way we also get clinical oversight and assurance from the Care Professionals Board for Lancashire and South Cumbria. So the 2 policies that you have before you today have been through that process. The first one I'd like to tell you about is the policy for commissioning spinal injections and radiofrequency denervation for low back pain. So this is an example where actually there was a policy in existence, but oh, sorry, my button's wrong again, isn't it? Okay, I'll try and keep an eye on that. Sorry about that. As I said, the policy for commissioning spinal injections and radiofrequency denervation for low back pain. This policy is an example where 2 of our CCGs across Lancashire and South Cumbria had addressed this area by a commissioning policy because they had recognised that it was a significant issue for them. And when we established the new group, they actually informed the Lancashire-wide group of this and suggested that this might be something the rest of Lancashire and South Cumbria would like to look at. Which was agreed. So the CPDIG, as I will call our current group for ease of reference, took up this policy at the point of engagement because the policy had gone through a local process prior to us having it. So it did go through extensive clinical engagement with our local clinician body, and also through the North West Coast Strategic Clinical Network. And a number of changes were made to the policy as a result of that engagement. They were not changes to the material commissioning principles that were there. They were changes to give additional clarity of wording for clinicians and for the public. So the core eligibility criteria within the policy you have today are unchanged from those in the existing Pennine Lancashire policy. Care Professionals Board, when they looked at the policy, were supportive of it and happy to recommend its onward movement through the process. So as I've said, only 2 CCGs had any policy in place previously. For the remaining CCGs, there were 3 who are listed in the paper: Chorley, South Ribble, Greater Preston and West Lancashire. Did not have any existing policy in place. So this is an entirely new policy for them. For 2 CCGs, the Filed and Wire and Morecambe Bay CCGs, there was a policy that addressed aspects of this but didn't have the same scope as this. So this is a wider policy than had previously been in place there. In Blackpool, there had been something, but it was not aligned with NICE guidance, and so we updated it to bring it into line with everything else. And as I've said, for the 2 Pennine CCGs, it's completely unchanged. The net impact of this policy is to bring clinical practice across the whole of Lancashire and South Cumbria in line with the prevailing national guidance on the As a side effect of that, because of the different histories in the various CCGs, the introduction of this policy is actually expected to release some resources. And that is because in some areas where we didn't have policies, or we had different policies that were not entirely up to date with West clinical evidence. We had some of these patients receiving these injections where actually the evidence is that they wouldn't have been receiving a net benefit. So that's the reason for the change.
I'm sorry for interrupting you. I'm just going to move your tablet away.
Oh, do you think that's what it is?
Well, it's just a test.
I'm going to get, yeah.
It might be that we have to ask people to turn their phones off if that continues.
I don't have a phone, but maybe
it is disruptive. Okay.
Sorry about that.
It's all right.
Okay. So I was saying that, yes, so there's an expectation that we may see a release of some resources away from the use of these injections where they've been used in a way where the evidence is that they wouldn't have been actually giving a good clinical benefit to patients. And that is likely to be of the order of £300,000 per year. So that would be resources released to reinvest in more effective treatments. So, and just lastly to say that neither the public engagement nor our equality impact assessment process identified any necessary changes on those grounds. And so that's why the policy group has now said that we feel it's ready to come here for ratification.
Okay, thanks very much. Any questions or comments?
Mike. No problem with a PAN system policy, of course, and no problem with the policy itself. Just a question about the transition. So we will have patients who may fall out with the policy but are already in the system and expecting a procedure. Can we confirm that they will get procedure as has been promised, or will they mid episode of care get stopped in their tracks? Assuming we agree this.
Certainly, Jeff. We have a general principle that we've agreed across Lancashire and South Cumbria for all of our policies, that where we introduce a change, any patient who's already partway down the treatment pathway carries on with the pathway and the policy that was in place at the point at which they were referred for that intervention. So the change will be for new patients. And we have contractual processes and other processes that Becky knows a lot more about than I do about how we do that.
Could I ask if you're speaking, if we could switch our microphones on? I think most people in the room can hear, but it probably won't pick up on the live streaming. So if we could try and remember that. I know it's not easy, I know. Okay, any other questions or comments? Mark.
Thanks, Phil. I hope this is working. Once we've agreed these policies, or the LAM, and hopefully we do agree them, what's the process with regards communicating these outside to providers? Because we had the discussions last time. We've been a bit lost back at the ranch about how we communicate these out to providers. So that's the first thing. The second one is again, I've picked up that, and I don't know whether this is an overly bureaucratic approach or whatever, but I'm told that providers are required to sign a contract variation to agree these. So if we're commissioners and we're agreeing these, why are we asking providers to agree them? Because I know that we're having particular issues with the ALHT in getting them to agree these. My view is if we've agreed them and there are HRG codes that sit with them, we just don't pay for them.
Okay, I'm going to start and then I'm going to hand over to Becky, who can give you a lot more of the specific detail. And if it's helpful, I'll take your second point first, Mark. And that is that it's our understanding that the standard NHS contract has provisions in it for how contract variations should take place if there's a level of potential change to providers' income. So there are clauses in the contract about the amount of notice that is there. And I think there is a degree of variation across Lancashire and South Cumbria about what's been negotiated with individual providers. But I'm going to hand you over to Becky to tell you a lot more about that.
Okay, so the first thing I'll pick up on is how is it communicated. So it can vary depending on the nature of the policy that is being introduced. In general, it is communicated via a formal contract variation to providers. They have obviously been involved in the consultation throughout the development, so they are aware that these are policies that are due to be implemented in year. So there is already an expectation that those policies will be implemented by CCGs. But contracts teams do issue formal contract variations, and then there's an internal process within trusts via which their contracts team will cascade the information through directorate managers and things like that. again, in terms of why there is a need for them to agree, it does come back. This is my understanding. We do have a contract rep who sits on the policy group, but that there is a need for it to be mutually agreed unless there are other systems in place, such as a prior approval system, whereby a contract variation isn't via mutual agreement. You can just vary it directly into the contract. So it is to do with the way the contracts are formed, but we are working with contracts representatives to understand what's the least bureaucratic and easiest way for clinical commissioning groups to vary these into the contracts.
Yeah, Amanda.
So, not wishing to offend anybody, well, actually not that bothered. We are talking like purist commissioners circa 2013, and the whole point of developing an integrated approach to care is look at our two things: our total resource and how we prioritise how we use it, and what is the clinically appropriate thing to do for our community. And there's a combination of those two things picked up in this policy development work. One is, what's the clinical evidence, what's safe, what's going to make people better, and let's do things that are going to do that, and let's stop doing things that aren't going to do that. And the other is, we've got a limited resource between us with which to improve the health of our population and improve the clinical care we give them. How do we prioritise how we spend that, and which interventions are more of a priority for us to use our resource on? And both of those apply in these conversations. If this should not be a different and separate viewpoint from commissioners, from providers. The Care Professionals Board is largely providers, and they have agreed these policies. If necessary, it's easy enough to get the Integrated Care System Board, which again has a lot of providers at the table, to agree these. But the approach to implementation will never ever work if it becomes contracting person A gives 6 months notice to someone in a trust who cascades it down a management route. Because the people who do this and spend the money are the GPs who refer and the consultants who actually carry out procedures. And so the implementation of this has got to be around engaging the clinicians in the pathways that we are going to have in Lancashire and South Cumbria, and how we make change and encourage change in that. So I just feel really, really uncomfortable with that conversation and those answers, because we just need to move away completely from that. And if there are HRG codes that apply, and we are all using PVR for what are largely elective interventions, we just zero tariff them locally. That soon solves the contracting discussion. But the bigger discussion is about clinical practice and how we communicate to our patients what's the right thing to do, and how we communicate to our clinicians why we're making these decisions and how they are expected to change their practice. I'll shut up now, having offended everybody.
Right. Any offended person wants to speak? Or Penny?
It's building on what Amanda just said. One of the keys to the success of implementation in this policy in Pennine, Lancashire, was educating the clinicians about, you know, the quality, safety and effectiveness of this policy. So I'm just wondering, how has that been thought about for those CCGs that haven't yet had to implement it?
Okay. Thanks, Penny. I would absolutely agree with you, and I guess it's about what we can do with the resources we have available. We are mainly tasked with the development and implementation. We go to great lengths to try and engage as many clinicians as possible in the policy at policy development stage, and again when it goes to Care Professionals Board, as Andy will confirm. We do a lot, as much as we can, to send out comms to make sure people are there. At some point, I think it comes over to the local health economy to be following up those conversations. And so I think we do as much as we can within the remit that we have.
Mary?
Could I just reply to that?
Yes.
I think then if we are going to be signing up to this policy across, you know, I think if we as commissioners sat here signing up to it are also signing up to a programme to educate our clinicians.
Mary?
Thank you, Chair. I think in a way Penny's probably made the point I was going to make. I mean, Amanda's right in everything that she says, but we all know that systems sometimes take a long time to catch up with the intentions and the wishes and a different way of providing and commissioning services. So I think Penny's point about educating the implementers, so to speak, and maybe this committee could ultimately have a role in facilitating any blockages there are in the system in terms of removing them and streamlining this, so the policies, once they're approved in future, go straight into implementation, and there's no argument or disagreement about what the intention is and how they have to be taken forward. So we probably have a later role to assist where we can without over-bureaucratising, if that's the word, the process. So I think there's probably a bit of work for us to do as a committee. Thank you.
Mark.
Thanks, Phil. I think I agree with everything which said. I think we do need some communications from this committee, which has got probably all the logos on for all the CCGs, which says that they've all agreed to this, which will be a first, I think. But I do think, as Penny said, we will work with our GPs. I think the point that Amanda made around the wider clinical discussion won't happen, because what we're finding is that there are some consultants who are saying, right, okay, I'm carrying on. That's the thing which is causing some issues, I think, with them. So GPs will do their bit, absolutely, but how are we assured that this is going to be properly responded to within providers? And I guess, Amanda, it's the discussion at the ICS board, as you talked about before.
So I agree with that. Don't underestimate the power of not paying for something. Not with the individual consultants, but with the people that are working with them and scheduling things in theatres and things like that. But the other part of this that we haven't talked about is not just how do we roll it out, but how do we monitor implementation. And one of the very effective ways of doing it is saying something which says, look, we've said this is our policy. This is the benchmarked information about how that's being implemented and adhered to across the various health economies. So how many of those things are still happening inappropriately in each part of the patch? Because the clinicians notice that stuff and ask questions and remember that stuff was talked about. But you're right, it's not easy.
Elaine and then Andrew.
Okay. You've led us nicely into monitoring and implementation, so thank you, because that is part of our remit. And I just thought it would be useful to reiterate again that it is part of our remit and that we've been working with colleagues in our business intelligence teams to get appropriately granular information at procedure level across all our providers and CCGs. And in fact, at the October meeting of the CPDIG group, for the first time, we had information of that granularity for the policies that you ratified on our behalf back in March. So things like tonsillectomy and hip and knee arthroscopy, etc. We feel quite well assured by that, but one of our actions that we've taken is potentially to follow up by sending that to the Finance and Investment Group for the ICS so that you've got that oversight as well and it's visible to you. So it's coming your way, Gary. Yeah.
Andrew.
So we will take an action from the discussion about the confirming through this implementation group how we communicate out to the system. There are some established ways of doing that. You're now getting some assurance that there is a monitoring role and a process to raise further concern. So we'll take account of that, Mark. And I think one of the subtleties about these policies is that they're not necessarily always about no treatment. There is obviously, this is permit up to 2 treatments. So there is a subtlety about the way that monitoring takes place. But the fundamental point about how we communicate it and how we use the ICS structures to manage the implementation, I think, is being heard.
Mark, yes?
I'm assured by that from Andrew, but I think we just need to watch that we don't end up in a position, so being an accountant, I've been in this many, many times, where we end up with inappropriate balances between organisations, and when you submit agreement of balances exercises, you don't balance and you fix things. And the reason that we don't balance is because we haven't been able to agree these policies, so you fix it. So it never happens. So we really do need to push on in the right way and make sure that this happens as a system.
Anthony.
Yeah, thanks. I recognise the concerns that have been made, and I'm not underestimating them, but just want to make sure that this isn't all just an ICS conversation. For example, in Morecambe Bay, we're trying to share the policies as they're drafted with our local trust, in case there's anything untoward that they can spot, that we can make sure that they feed back to you, and I think they've been doing that. We're also trying, wherever possible, to build it into the work that we're doing. So it's great that this is coming along at the same time as we're redeveloping the model for pay management. And most importantly, I wouldn't want to lose the focus on doing the right thing for patients in the focus on the money, because we shouldn't be injecting people where there's not clinical evidence that it's right to do so. And that's the most important thing for me in this, and making sure we're clear with the public on that. Now, I do agree with the points that have been made, that we should be making sure that this is backed up into contracts as well, because if the worst comes to worst, then we have got the contractual basis on which to land this. But first and foremost, these should be the clinical discussions, as colleagues like Amanda have referred to, across the ICS, but locally as well, that this is doing the right thing for patients.
Okay, I've had Sue indicate. Is there anybody else before we take this to a vote? Oh, it's Doug, yeah. All right, Sue and then Doug.
No, this has just prompted a broader question around communication with people, in as much as I'm wondering the extent to which people realise that there is such a robust policy framework that informs the decisions that are taken about their care. And now that we're moving to a much more uniform approach that's agreed across a number of CCGs across the whole of Lancashire and South Cumbria, whether it's an opportunity to help people understand that where they are perhaps denied treatment or offered particular types of treatment, that there is a policy framework that does indeed inform that. Now, people around the room might know better than me as to the extent to which people know and understand that, but I think it is an opportunity to perhaps make that clear across our population.
So Neil might want to pick.
All right.
Yeah, I think there's a huge amount of work that we're doing to actually help people to actually understand some of the decisions and some of the things from these policies. So I think we'll definitely take some of that into account. Yeah.
Okay, Doug.
I echo Mark's points that having been through a number of very high value contract arbitrations and disputes, what might be worth doing is whether the joint committee could come up with a form of wording regarding how we implement these things that we all put in our contracts next year, so we do it, make it very clear what our expectations are, and try and negotiate that into the next year's contract.
Penny?
Just to add about the communication, obviously I'm a commissioner, I'm also a GP, and it was only at the last meeting of the JCCG when Elaine explained the process as she did today, did I realise what a robust system, both clinically and financially, that these policies have been through. So if I only just realised that, I think we have a massive communication opportunity for our public.
So I think you're right, Penny. We absolutely do. But actually, that's what CCGs are good at. That's our job, is to engage with our local community and our clinicians to make sure people understand that. So the onus is really on us to take that back. Just on Doug's point, that is helpful. Certainly in Blackpool, we have on the bottom of all referral letters from GPs, simple shoulder and knee injections in theatre will not be funded. So it's really clear to the clinician reading the letter that those things won't happen, as well as being written into contracts and things. And so there are things we can do jointly that make that really clear.
Okay, so perhaps we could go to the vote on this as to whether we accept this policy, subject to the suggestions that have been made in the discussion here and the safeguards and so on. So is everybody in favour of this particular policy? Yes. Anybody against? Thank you. So we go on to 7B, Policy for Assisted Conception Services. Elaine.
Thank you, Chair. Okay, so we're in a different situation with this policy in that all of the Lancashire and South Cumbria CCGs have previously had policies for assisted conception services in place, some of which will have been inherited from legacy PCTs. So there's been a commissioning policy approach to these services for a large number of years. And the trigger for the review at this stage was that those legacy policies had reached their review dates. When we took this work on, we were very clear about what the purpose of it was, and it was really fourfold, or in many ways. So the first task we needed to do was make sure that the policy was aligned as much as possible with the current evidence base of best practice. Some of our policies were quite behind in terms of what they'd considered as best practice and the evidence base. The second thing was, as we have been tasked with everything, is to actually harmonise eligibility criteria across the whole footprint, because again, we'd had quite significant variation. And part of that variation was about some policies not addressing certain circumstances that were addressed by some other policies. So that was our third thing, was to make sure that our policy was comprehensive enough to cover all the potential scenarios that we could envisage whereby someone might approach for the NHS for treatment to assist conception. And last but no means least, we were tasked with doing all of that in such a way that the provision of these services would remain affordable to CCGs and therefore contribute to the effective use of NHS resources. So that's where we started from. The policy went through the process that we discussed earlier on, and before I go into any of the specifics of the policy, I think it's important to talk about the outcomes of public engagement, which are actually slightly later in the paper under section 4.9. But just to say that of all the policies that we've done so far, this policy was the one where we got by far the biggest response at public engagement stage. Hundreds and hundreds, in fact, possibly over 1,000 responses. Obviously, people feel very strongly, and there were a number of points raised within the public engagement exercise which we needed to take further advice on, because we took that very seriously, and so we did that. We went back to the evidence base. We looked at what felt like it would be most equitable, because some of the things that were raised were about equality, potential equality and equity issues. And we also, in a couple of areas, actually took legal advice about what might be an appropriate way forward. So, having done all that, we had a new draft of the policy that was quite significantly different from the original draft, which had gone through clinical engagement and gone to Care Professionals Board. So we took the so far unique step of actually taking this policy back for further scrutiny through Care Professionals Board for a second time. And I'm glad to say that Care Professionals Boards were supportive of the changes that we'd made and the rationale for them. And so that is the policy that you see before you today that has gone round that extra loop because of the materiality of the changes in response to public engagement. So I will take you back to section 4.4 and just go through briefly an outline of all the changes that have happened in the policy, because there are quite a number. So I'll try and be concise, but I think it's important to explain them. One of the first things to say is that when we first looked at this, we wanted to understand what was currently happening for our patients across the various providers. What was previously talked about as an IVF cycle, what actually went into that in terms of the interventions and that patients could receive. And what we discovered was that there was significant variation between our providers, both in what exactly was covered inside one cycle of treatment, so notably how many potential embryo transfers they might be entitled to before the cycle was deemed to be finished, and also in the costs and how the costs were attributed by different providers. So I don't want to go into detail, but what it showed us was actually we had a much bigger inequity than we understood, because we had inequity of access at the commissioning end and inequity of provision at the treatment end. So one of the first things we thought was really important was to be absolutely clear about what we would expect providers to deliver to our patients for one treatment unit. And in doing that, we went to NICE guidance. And so we have adopted the definition that is in the extant NICE clinical guideline on this, which is that one treatment unit or cycle should involve the transfer of all embryos created from an episode of ovarian stimulation until either a pregnancy leading to a birth is achieved or no embryos remain. And I want to be very clear that we are talking about one embryo at a time. So we are not asking providers to transfer multiple embryos, because the evidence is that that is, leads to a potentially more risky pregnancy. So we're saying if you do not become pregnant in the first, second or third embryo transfer, which is where most providers would potentially have stopped their current treatment, if you have additional embryos, that you should have access to those under your treatment cycle until they're either all gone or you've actually had a successful pregnancy. So that's a significant change to what we're saying is included in one treatment unit. And it's important to keep that in mind for later. I talked about the variation in cost and charging methods that we uncovered. That has actually been recognised nationally. So and as a result, there's actually a national working group has been established to look at developing a set of benchmarked prices for assisted conception technologies. That work is currently ongoing. It's been ongoing for quite some time. But the current expectation is that that will come out in time for it to be incorporated in 2019-20 contracting year. So we await that with anticipation. Okay, as I've said, there's a number of characteristics within the policies where there was variation between CCGs. So the impact on each CCG of the policy that we brought before you today will be slightly different, and the paper goes into the detail of that. Before we move on, I would just like to finish the discussion about costs in terms of because the net impact of this policy is to extend access to some additional patient groups to greater or lesser degrees across the whole of Lancashire or South Cumbria. In so doing, that creates additional cost pressure for commissioners. If I remind you that we were tasked with coming up with a policy that did allow that extended and more equitable access while remaining affordable. And that is the rationale for actually saying that what we're proposing to be commissioned is a single treatment unit. Some of our policies in the past, most of our policies have had 2 cycles. It's a very complex idea that it's possible now for one treatment unit to actually give patients access to more embryo transfers than 2 previous cycles might have been. That will be dependent on the individual patient, how many embryos they are able to create, and how many it takes before they achieve a pregnancy. So very difficult to quantify, but that's the concept, and that's where we're coming from in proposing one treatment unit. And I'll come back to what we think we'd know about what that impact of that might be financially later on. So people are happy so far. I'm just looking to make sure I haven't lost anybody yet. I'll move on to section 411, which is the summary of the key changes. So the most straightforward one is that NICE guidance had moved on since our previous policies had been written. And the NICE guidance actually has an increased upper age limit for women accessing this treatment. So we have applied that to our proposed policy. Only 2 of our CCGs had already applied that in their existing policies. That was Blackpool and Morecambe Bay. So for every other CCG, there will be additional patients eligible for treatment on age grounds, as they will now be within the age criteria. In terms of lower age or age of initial access to this treatment, we had 4 areas where... Chair,
can I just say, I don't think a few of us have got a section 411 in our reports. Is this a...
So it's in the cover paper, page 5 of 7. Sorry, I'll give you a second.
We've got new policy.
Yeah. I don't know what page is it in your pack. It's just 5 of 7. Yeah. It's page 5 of 7.
I think it might be Blackburn with Darwin that haven't got 5 to 7. Probably our problem. It seems to be this end of the table. East Lancashire have it.
Ah. How could that happen?
Yeah, we like to keep you in the dark, Graham. It's all right.
Okay.
Successful.
Yeah.
Are you happy for me to continue? Is that all right? Okay. So apologies for that. So lower age limit. 4 of our CCGs had previously had a lower age limit in their policy, which was the age of 23, and that was something that had come from previously existing NICE guidance. The current NICE guidance actually doesn't include a lower age limit for access to treatment, and we did a lot of thinking about that, and I think also took some legal advice on what would be a reasonable way of defining a lower age limit, and we settled on the age of 18, that being the legal definition of adulthood. So that's the reason that that's in there, and that's the reason that 4 CCGs will see additional patient access, because previously in those CCGs you would have had to wait until the age of 23 to be eligible. Okay. The next criterion where we've made harmonised things is around the provision of treatment where living children exist from either of a couple who wish to access this service. 2 of our CCG areas had previously allowed access to treatment where either individual within a couple already had a child from a previous relationship. We looked at whether it would be possible to extend that to the other 6 CCGs. The difficulty of estimating the potential impact of that meant that we were unable to quantify how big an increase pressure on resources that would be, and therefore it was felt appropriate to actually stick with the other CCGs, the other 6 who had said no, that if there was an existing living child, then there would not be access to services. So it's done really on grounds of affordability and going with the majority position. Okay. The next section talks about couples in same-sex relationships and single women. This is a situation where we had gaps and inconsistencies within our legacy policies. So as a result of including these groups in our eligibility criteria, there will be 3 CCGs where there will be increased access. Those are Blackburn with Darwen, East Lancashire and Fylde and Wyre. Patients in 3 areas will experience a higher threshold for access, those being Chorley, South Ribble, Greater Preston and West Lancashire. And I would just like to explain the higher threshold for access when you get into the detail of the policy. People in these situations need to demonstrate, well, all patients need to have demonstrated clinical infertility to access services. For these patients, it's about having undergone a number of rounds of intrauterine insemination, and there was variation in what CCGs expected. We have gone with the NICE recommended number of cycles, which is 12. So some patients would previously only have had to undertake 6 or 9 cycles, but we're now asking everyone to undergo 12, and that's on the basis of that being NICE's position on the subject. And the last 2 CCGs, Blackpool and Morecambe Bay, there's actually no change because they already included these patients in with the same thresholds that we have now. Everyone happy? Yeah, okay. The next area is one where we'd recognise that things have moved on in many ways and technology has moved on, and our understanding of what we can do for patients has moved on. So the policy now includes access criteria and storage periods for gamete cryopreservation. Now that's not necessarily embryo storage, that may be for patients who are about to undergo cancer therapy or any other kind of treatment that would actually potentially render them clinically infertile because of the treatment that they have to have for another condition. So we've now addressed that within the policy and said that the NHS will fund gamete cryopreservation for that purpose within the policy. Okay, and so that actually means that patients in all 8 of our CCG areas will have access now because we hadn't addressed it in previous policies. Okay, I've talked earlier on about definition, a clearer definition of what we expect to be included in a treatment unit. That will mean that regardless of which CCG any patient comes from or which provider accesses the access for treatment, they should receive the same opportunity of intervention across the whole area. And as I've said previously, the flip side of that is that we've said that larger unit of treatment we will offer once for the larger group of patients. And okay, so I'm going to stop at that point and just check that people are clear of what I've said, and then I'll come on lastly to the potential financial impacts. Does anybody want to?
Can I just make one point? That it's my understanding there's now an outstanding High Court challenge over one of the aspects of
The gamete preservation.
The gamete
Transgender.
preservation. And I think what we need to do is recognise that's ongoing and recognise that should what we agree differ from what the High Court says, we then have the agreement of this committee to amend the policy without bringing it back.
Yes. Just for background, that is about gamete preservation for patients about to undergo transgender reassignment processes, and under the policy that's before you today, they are included, so they will have access under this policy at the moment. But we do need to, we absolutely do need to check that. But it was done knowing that that was there, and therefore feeling that that was something was important to include.
There's a question, I think, as well.
Yes, thank you.
Sorry,
Yeah. It's just the question about eligibility with couples with pre-existing children, which I sort of kind of get and agree again, but the question is, like the High Court question, are we contravening a human right here, in the sense that if we turn down someone's eligibility on that criteria, most people will then go and pay privately for the treatment, but there will be some who cannot afford to do that, and therefore are we contravening any human rights? Have we taken legal advice on that? Because there is a right to have children, I believe.
Yes. Oh,
So the advice is that this policy from a legal point of view is robust.
Okay.
I'm not sure there is a right to have children.
You don't think so?
There's a right. It's not whether I think, it's whether actually legally there is a right to have children. And there.
I'm going to let Becky tell you a bit more.
So we do a full equality and impact assessment as part of our process, and for this policy we actually also did a human rights assessment, and it didn't actually raise any concerns. I think, drawing on the point that Amanda raised, I think and I'm not an equality and inclusion specialist, but I think the right is to a family life.
Family life, yeah.
But that it wasn't deemed to contravene that right. There were no concerns raised because obviously the definition of family is quite widespread.
Okay, I think let's move forward then.
Okay, thank you. So I will just come back lastly to the question of financial impact of this policy. So you'll see from the paper that our current estimate of annual expenditure on assisted conception services from our main providers across Lancashire and South Cumbria is in the region of £2.5 million per year. You'll have recognised from previous discussions and discussions on the previous policy that part of our remit is to try and model any financial impact of proposed changes to policies in whatever direction they may arise. In the case of this policy, that has proved to be virtually impossible. And the reasons for that are twofold, really. One is that there isn't published population data about people's characteristics down to the level at which we are asking for information. So, for example, exactly who's in a same-sex relationship or has need of IVF with existing children. So there aren't any nationally available public health type data sets that would cover that kind of information. And the other thing is that while our providers may well ask many of those questions of individual patients when they're assessing their eligibility to a treatment or looking at what might be suitable for them, there's no requirement for providers to collate that data and report it anywhere. So we have even gone to the lengths of contacting the Human Fertilisation and Embryology Authority to ask them for their help, and they have the same problem we do. And it is also related to the national work around pricing. So very, very difficult to estimate anything. What we did do was to say to our providers, to ask our providers what information they would be willing to share with us without breaching patient confidentiality on an idea of how many of the treatments were treated under a second cycle under our old definition. And we got a little bit of information from one provider. So we think there's an expectation that there will be a saving. I'm not going so far to try and put a number on it because we have no confidence in being able to do that for the reasons that I've explained. But what we feel is that the potential saving from those fewer, where we would have been charged for 2 cycles and will now be charged for 1 treatment unit, that will give us a little bit of headroom, which we hope will be sufficient to cope with the additional cost pressures related to the additional access that we've created within this policy. We've talked earlier on about how intensively we will monitor these things. We will be doing that. we will also be waiting with expectation for the national benchmarked prices to see how they fall in. So, and as Becky's already explained, we've done comprehensive equality impact assessment, and all of the equality queries that were identified either through that or through the clinical or public engagement route have been addressed in the policy that's before you today, some with the benefit of legal advice and as to how we did that. So I'm happy to stop there.
Okay, well, thanks very much for that, Elaine and Penny. We have had some briefings on this before for a number of members of the committee. It's a complex issue, it's an emotive issue, but thank you for the work that you've done on this. Are there any questions in relation to the presentation we just had? Roy.
Thanks, Chair. It's not really a question, it's a comment, I think. And it's particularly about this policy, but it's also about generic policies as well that this committee deals with. And there was comments earlier about how we actually communicate these policies down, not only to people around this particular room and to GPs, but also to the patients that are affected by these policies. And I know we all feel that's really important. In Blackpool, where we've changed policies, we've often provided GPs with a handout to give to patients to explain the reasons behind why we've changed that policy, in particular, how that policy affects them. I think any of us who've sat on IFR panels, individual funding request policies or panels, or actually their appeal panels, will recognise that we do often get a lot of appeals regarding this particular issue about assisted conception. I think it'd be really worthwhile us thinking about providing some standardised handouts that we could actually send out to perhaps practices and GPs that explain these policies and explain the reasons why we've made these decisions. And it would help, I believe, the GPs, in fact, because I think we all know, when I talked about the AFR panels, that sometimes we do get letters from GPs supporting the individual patient with regards to their concerns. And I think to help those GPs, and I do recognise it is difficult in a 10-minute consultation where you're trying to explain to a patient quite a difficult and complex issue. If you had something there that you could give to the patient and explain that position, I think that might be helpful, Chair.
Elaine, to answer. Mary, is it on the same point, or before Elaine comes in, or something different?
Well, it's a different point, Chair.
Okay, well, Elaine, perhaps answer that one.
Okay. Yeah, absolutely understand what you're saying and agree with you. What we have done for this policy in particular, because we were cognizant of the fact that there's a lot of jargon and technical information in this policy, and some of that has been added to on the basis of legal advice. So where we tried to simplify things, we've had to make them slightly less simple in order to be clear that we were on firm legal grounds. So what we have done is we've worked with some comms colleagues to produce what we're calling an easy read version of this policy. So it's not a document that's about the policy changes so much, but it is a document, and it's a leaflet, a patient leaflet with pictures, and very user-friendly to look at, which explains what we mean when we talk about assisted conception. So that's already ready to go out. I don't know whether there's anything else you'd want to say. Oh, in fact, it's here, if you'd like to look at it later. Thank you.
Once you've prepared
almost like we prepared it, yeah.
Okay, Mary.
Thank you, Chair. One is a question and the other is a comment. My question to Elaine and Becky is about the review process for this policy. I'm recalling at our last meeting, I think you did explain that there was a standardised review process for all of these policies. Just like to hear that confirmed in relation to this, and also what trigger events might mean that it would be reviewed much earlier than the normal arrangements for review. That's the question. And the comment I wanted to make was really echoing something Penny said earlier. I've been hugely impressed by this policy development process that we have in place. I think some really, really good, robust work is being done. I think it's absolutely essential that we have this process in place now and for the future. But I would like to have it placed on record our thanks to Elaine, Becky and the team for, particularly in relation to this policy, which has been extremely complex, that as far as I'm concerned, they've left no stone unturned really in terms of addressing our questions and following up issues that were raised with them during the course of developing this policy. So thank you for the work you've done. we just expect more of it in the future.
Amanda wanted to
I'll just pick up the answer to the question. I absolutely agree that they've done a great piece of work on this and all the other work they're doing. The review issue, there's two things that might trigger a review in this and other policies. One is new clinical evidence or information, which could apply to any of our policies and which might make us change our criteria or relook at the evidence about what's effective. The other is, and this relates to this policy maybe more than to some of the others, but some of the restrictions we are putting in place are because we cannot afford to help everybody with assisted conception who we would like to if all other things were equal. So one of the reasons for this policy is that we've got to prioritise what we do with our funds at the risk of being boring and saying the same thing again. We don't have unlimited resources, and we recognise there are many more people who would like this intervention than we can afford to help. If for some reason, before the review date of this policy, we were in a financial position where we were able to relook at some of our commissioning policies, then we would do so. I think we have to put that again applies to anything that we are placing restrictions because of affordability.
Okay, Graham.
First of all, can I echo the words of it was a really excellent piece of work and very well explained even to me, so thank you for that. What I would like to really is follow up on Amanda's point, maybe from a slightly different angle. I mean, I'm extremely uncomfortable about approving an open-ended commitment with no financial information. I understand why we have to do it. I understand why it's very difficult to collect that information. I was going to ask a question about this policy being reviewed. Now, clearly, we haven't got the information to make a projection of the costs, but clearly you've already got information about the actual costs of the current policy. So presumably you'll be able to collect that information after, say, a year or 18 months of this policy being in place. They've had like some assurance that if we find that this new policy is costing in excess of the 2.5 million, then we'll have a chance to bring this back for reconsideration. Because as has been said several times, if you spend money on this, we're not spending money on something else. So if you give me that reassurance, I'd be happy to vote for it and say that if maybe in 18 months' time or a year's time, this can be brought back with tell us the actual costing of this policy.
Yeah. Yes, Graham, certainly. This policy will be subject to the same type of monitoring as we are putting in place that we've worked quite hard with colleagues in business intelligence to make sure we can get as much detail as is available to commissioners. And obviously there are additional sensitivities around detail around this, but certainly absolute costs we will be able to track. I would say that when I talked earlier on about the variation in costs between providers, I think that was of the order of about £1,500-ish between the lowest and the highest. And we know that we've got this wider context of the national benchmarking work. My view is that there is a possibility that the national benchmarking may put the cost of every treatment cycle closer to the top of the range that we've been paying rather than the bottom, and that actually that may be the thing that impacts on costs rather than the absolute number of cycles. But we will be able to monitor both, and we will absolutely be speaking to Gary and the FIG at the earliest possible opportunity to show them that data and then to agree if it needs to trigger a review.
Well, it's just so happens that Gary's the next person to speak, followed by Penny. Is there anybody, could I ask if there's anybody else likely to want Doug after that? Anybody else afterwards? Just to get an idea of time. Thank you. Gary.
Yes, I was asked last time some colleagues were having discussions about this policy in the draft stage, felt that perhaps the amount of money that had been identified against spend wasn't as large as one might expect for Lancashire and South Cumbria. So I did ask for the data files from our colleagues from the CSU, 6,500 lines of information and about 40,000 data items. And I tried to see whether or not there was any pattern in there. And we did a few analyses. I asked Becky if they could do some additional pivot tables. But I have to say, from that information, although there's loads and loads of data, there wasn't a particular pattern. The only pattern there was in there that different providers charge for different things. So one of our providers charges for every single consultation separately, bundles them together and sends us the total cost for a CCG's patients. It might be 52 in a period, whereas other providers just say the total cost for the cycle is X. Trying to unpick that and trying to attribute that, trying to attribute any type of pattern was extremely difficult. So based on the data we've got, I even went through and did some manual calculations on this just to check, and the data that, the analysis that the CSU had undertaken checked out. There didn't look like there were any mistakes. I'm not saying that I'm the bee's knees at doing this. It's just to say that another set of eyes has looked at the data that the CSU looked at and came to the same conclusions about this. So I fully concur with what our CSU colleagues are saying about the difficulties in being able to estimate the impact of this policy. But the costs that we are incurring as CCGs is as stated in the paper. And I think there's two things to say to the point that Graham's just made. I don't really think it's easy for us to take into account what's going to happen around the prices. I mean, trust prices go up. Sometimes they go down, but trust prices go up, and we just have to live with that. So the cost of acute services, if the price goes up for that, we have to pay it, and I would suggest it would be the same for IVF. And other assisted conception technologies. Secondly, we will, you know, whether or not the judgment call is that the 2.5 million could become 10, 15, 20 million, it doesn't feel like that's the judgment call around this. It feels like it'd be much nearer to the 2.5 than it would be bigger figures. We don't really know for certain. But there's nothing in the work that's been undertaken that would suggest that that range of costs could be substantially greater than the costs that are already being incurred. But obviously, we'll monitor that.
Okay, thanks for that reassurance. Penny and Doug, and then nobody else indicated, so we'll take a vote after that. Thank you. Penny?
Thank you, yeah. I think going back to Mary said about no stone unturned, and then you waive the leaflet that might be available to patients. I think that is absolutely fantastic, but perhaps like to think about whether we could extend it from a patient leaflet. Because the assumption with this policy is that we are restricting people's access. And actually, we're not always doing that. So, and Roy pointed out sometimes the pressures on GPs who might not know necessarily what the policy entails. Only this week, I had a 24-year-old who came and said, there's a policy coming on the 1st of November, I need to be referred today. So the misconceptions that there's going to be restrictions. So I think the more we can do, perhaps GPs, providers, all providing the same information in a brief form about what can be expected of a referral will save an awful lot of angst and work in the system.
Thanks. I think misconceptions has another meaning as well.
Yes.
All right, Doug, and then we'll take a vote.
I suppose my question is related to the earlier discussion. I mean, it's a great piece of work, but can we actually effectively police this policy when we adopt it? Most of our patients, as I understand it, will not be being treated locally. They'll go into places like Manchester, where most of the patients treated in that unit will be from that Manchester area. And therefore you'd expect the unit normally to follow the Manchester policies. Can we reasonably expect them to follow our policies for our patients?
Amanda said she'd like to deal with this, if that's okay.
These providers, perhaps more than any I've seen, are incredibly slick at following individual policies because their income is dependent on it. So they are actually quite good at that, so we can. On Penny's point, I think she's absolutely right. I think we also need to recognise that most of the difficult discussion with patients is not about the intricacies that are in this, the technical things that apply to a relatively small number of people. It's being able to present patients with information saying, unless you lose 2 stone, you won't qualify. Unless you've both stopped smoking, you won't qualify. It's the basics that are often the blockers for people and that they find quite challenging rather than the very small groups of patients who some of these things apply to. So we do need to understand it's that stuff that people want.
Okay, so I think we've given that a good airing. There's quite a bit of work being done prior to this, and again, I would echo the sentiments about the quality of the work and the thoroughness. So, we have before us this policy. Are all voting members in favour? Would show by show of hands, please. Is anybody against? So that's carried. Thank you very much. So we move on to item 8, where I think you're going to introduce this, Andrew.
Very briefly. So change of gear really now for the second hour of the meeting. I'm very pleased to welcome Gemma and Claire because they are part of the team working on the programme for stroke services improvement across Lancashire and South Cumbria. Remembering our jargon here, the ICS is effectively a partnership of commissioners, providers, local government, NHS and our communities. And in one sense, I suppose the introduction, the most appropriate is this is an interesting test case for us. If we think that it's effective for us to be working in partnership, then we ought to be looking at issues like stroke to see whether we can improve things. And we decided stroke was a priority some time ago. So the purpose in bringing the paper today, largely, was to bring colleagues up to date with all the work that Gemma and Claire are leading, but to point the way towards some future decisions, some future choices that we need to make as this programme comes to a critical stage. So that's the purpose today. Colleagues, if you're happy to introduce, please do.
Thank you. So as Andrew said, we've been working on the end-to-end stroke programme across Lancashire and South Cumbria, which was driven by the development of an end-to-end stroke service specification, which came about following a review of stroke services which highlighted variation across Lancashire and South Cumbria. So we've brought an update today just to give you a high-level overview and update on progress across each phase of the stroke pathway, just to highlight the work that's being done, which is significant, but also to show the progress that's being made. There is still further progress to be made to reduce variation in access to services, but also some of the decisions that we're expecting commissioners will need to make over the coming months, which range from decisions around models of care, investment decisions, amendments to a specification potentially, and for each phase of the pathway there are different decisions that will need to be made. What we're working through at the moment is the critical path in terms of the decisions which will need to be made and the sequencing of those decisions. Mine and Gemma's roles are very closely linked to the acute elements of the pathway and the stroke rehabilitation elements of the pathway. And it's how we reach a point where we have an understanding of the critical path around the decisions to be made and how the system can make those decisions very quickly so that we can move on with progress on stroke services. I suppose just to highlight as well, we've included as part of the end-to-end pathway, obviously we have prevention at the front end of the pathway and we also have life after stroke as part of the long-term support to patients as well. And as highlighted on page 2 of the report, we have a range of commissioning arrangements at the moment. And again, there will be decisions to be made, most likely in terms of how some of these services are commissioned. And in the work that we've done so far, we've had huge clinical and patient engagement in terms of the work to date. And we expect that to continue. We've had excellent clinical engagement in terms of development of models, development of the specification, and the work that's been happening most recently in terms of developing an alternative ambulatory model of care for in-hospital rapid assessment and diagnosis of patients. In terms of the patient engagement, again, we have done significant engagement with patients at various phases of the journey, and we are continually talking to patients about the progress against the programme and where we need to go next, with further patient engagement in the coming months. I haven't gone into any detail in terms of the report, but I'm more than happy to take any questions if there are any specifics. Gemma, I don't know if you want to say anything.
Just to add, and Andrew, you're absolutely right in terms of using stroke, I think, as a test case in terms of how we respond to the challenges that we're facing around this programme, as well as others, as a system, rather than commissioner versus provider, etc., etc. So You know, in terms of the acute and specialised portfolio, we have a number of other big programmes of work, but this is actually, stroke is much further forward because of the amount of work, modelling, etc., that the team have done. So I can't overemphasise enough, really, that, you know, this is very much how we respond as a system. And the engagement we've had to date so far has been absolutely amazing, particularly from commissioners, where we started off at the beginning of the year with people sort of looking at us as if, you know, well, what's the role for commissioners here? And actually now completely round the table, particularly from a clinical commissioner perspective in the work that we're doing to support the development of the ambulatory model, which is really sort of, you know, recognised as a national best practice. And we're lucky enough on the Stroke Programme Board to have Deb Lowe, who is the national lead for Getting It Right First Time, who chairs that, and I co-chair that with her. But she's also the clinical director and consultant over at Arrow Park, which is an outstanding hyperacute stroke unit. So we have somebody who's really supportive and informing us that actually we think that we're doing the right thing for patients.
I think just to point out as well, and I have included it in the paper, but the direction of travel for Lancashire and South Cumbria is absolutely aligned to what we understand will be coming out as part of the National Stroke Plan. So again, it's that reassurance that we are absolutely doing the right thing for our patients and the population of Lancashire and South Cumbria. And to have that reassurance is, you know, it's good to hear that.
Also, just this is a double act here, by the way, going backwards and forwards, just to reassure people, and hopefully it's sort of fairly clear in the paper, but we have gone through the end-to-end pathway, as Claire said. Our focus very much is around the in-hospital part. That's absolutely integral in terms of the rehabilitation part of that, and in terms of the model that we're working at, the rehabilitation bit starts once people are literally admitted into the acute stroke, hyperacute stroke unit. One of the decisions that you'll see that's in the paper is that if we say that we're not going to have a consistent focus around funding that particular part of the model, we really do have a difficult decision to make, because the ambulatory care model won't work properly if we don't have that as an integral part of that hyperacute and acute stroke care. So you'll see, as we've put in the paper, those decisions that need to be thought about. You know, that's absolutely integral. The other bits also you'll notice is that we really focused on the continuous improvement, which has been quite a shift, even though continuous improvement has been happening locally for a number of years. And certainly one of the challenges we've had at the ICS board and in other meetings, you know, it feels like stroke's been going on for years. Well, yes, it has, and it's really complicated. We've done quite a number of twists and turns, even just in the year that I've been in post. So the focus now on the continuous improvement, but particularly joining things up from each of the acute trusts to say, how can we share what's working really well? How can we start to think of this as a Lancashire and South Cumbria approach to stroke care? Because there will be parts of the patch that are advantaged over other parts of the patch. How can we start to address that? Certainly the rurality of the north part of the patch is an issue which we'll need to consider. So we have now got those people talking to each other and communicating and working together to address a Lancashire and South Cumbria improvement plan. So I can't emphasise enough, you know, as Claire said, that clinical engagement that we've had has been outstanding.
Okay, well, this report is for information, but one of the bullet points in the on the report is to endorse the programme and the work going forward, so perhaps bear that in mind. I've had indication from Jeff behind the pillar that you'd like to speak.
Yes, thank you. I mean, one of the things we're asked to note is the significant progress today and the focus on continuous improvement. I suppose my concern is long-standing one, and if you were to look at the board minutes of Chorley and South Ribble CCG, the angst that we express year in, year out about this particular area, we see action plan after action plan. We're always told clinicians are on board. It's not only the clinicians in a sense where a blockage might be, but I suppose I'm feeling sceptical in terms of what we have seen as a history of the data coming back to us, which frankly is worrying.
Shall I respond to that?
Oh, yeah, please, please.
Well, could you say, I've got two other indications. I'm just thinking of time as well, of three actually now, other indications. Perhaps we can, it may be covering the same point, so perhaps we could hear those, as long as they're not too complicated. we'll see later. Sue wanted to speak, then Peter, at the back is it Peter? And then, sorry, I've forgotten your name. Jeff, that's right. So if we could have those, and then we'll see if you could round up on that. That's okay.
Yes,
Right, so Sue first.
Thank you, Chair. Two short contributions. Firstly, I read this last night and then pointed out to colleagues who work in North Cumbria a little concern because the focus there is very much about the hyperacute stroke unit rather than the ambulatory approach. So within Cumbria, we appear to have a difference, although I completely understand the context is very different across North Cumbria because of the challenges around recruitment for a stroke consultant. But I just think in terms of Cumbria, we need to perhaps understand that and be aware of any risks that that might pose. Secondly, in Copeland, not least because of that work that's going on, there's a piece of work funded by NHS England through an organisation called Building Health Partnerships, where we've been working with members of the community to better understand their understanding of the criteria for stroke. And some very early analysis of the feedback coming from that is that people actually are really quite well informed. And one of the reasons they're well informed is because of a recent television advert that has been out. And so people are really getting to grips with what those criteria are and what they need to do as individuals in terms of keeping well. So I thought that's a piece of good news that's worth sharing in terms of communication that's working. Thank
Peter.
you.
Yeah, a slightly broader question, I guess, probably more aimed at Andrew and Gary. Clearly there's a financial aspect associated with this. From some bigger programs, there are also financial aspects emerging. Some of those require a prioritisation conversation and a collective decision-making conversation. And was there any thought as to how we take that forward so we don't run the risk of taking decisions on individual programs, but we need to look at priorities across the whole?
Okay, and then Jeffrey. Jeff.
Okay, thank you.
Is that better? Can you hear me? Two questions really. It might be just my ignorance this, because I'm not so well cited on this as I were the last two papers. But first of all, I can't see smoking in the prevention, and that just seems really bizarre. But is that because it's somewhere else in a different plan or a different, but it just seems really bizarre there's no mention of smoking. And the second point was, being one of the residents of an area where it's not appropriate for patients, etc., in Barrow in Furness, can you reassure me as a patient, a citizen, a GP, person who looks after patients, or my whole community that I commission for, that I'm not going to be disadvantaged by not having a hyperacute stroke? Because that's where the evidence lies, isn't it? And so, it seems to be, as someone else said, it seems to take a long time, and then we're being offered a different model. Where's the reassurance for us in the remote north?
Okay, so if you'd like to answer those, I think Gary is going to answer the finance one. Were you indicating? Yeah. Okay, do you want to?
So just responding directly to what Peter's just said. On the 15th of November, we've organised a seminar for our senior finance colleagues to warm them up to some of the issues that are going to be coming our way with regards to considerations around stroke. And I think part of that will be looking to take a wider view about how one assesses the financial impact of this, which is not only the benefits of people being saved, people having less disability, but the costs that are incurred from their longer term care, both within the local authority sector as well as in the health sector. So one of the things we think we've got to get right is when we're assessing the costs for this particular programme, that we're cognizant of the fact that this is the whole social cost. So we're beginning to think more as an integrated system about the way in which we assess those financial issues. And it is possible that this could cost the NHS more, some aspects of this could cost the NHS more, but maybe have bigger benefits in the local authority sector. So we're seeking to get input from our local authority colleagues to get that fully rounded view about the way in which the costs and benefits of this particular programme are assessed. In relation to the second question you asked, Jane and I are in the process, and I'm sure it will be with the rest of the exec team, of putting some proposals together about how we move forwards for the whole of the planning round. And I think the focus at the moment and the pressure that's on the relevant teams is whether or not they can bring forward their programmes so that we've got an indication of what the whole menu of costs is going to be for next year, so we could consider them all in the round and make sure that they are included in one go within our plans, rather than things dripping through and us either missing them because they weren't ready or not recognising that they are an issue. So we're looking to get that overarching view about that, and that will be become joint discussions between colleagues working at Lancashire and South Cumbria level and the individual integrated care partnerships and organisations, but also with our portfolios of work that are on with what they're doing at the moment. So I think we've done the thinking to cover the angles on this and make sure that colleagues are apprised of the up-and-coming significant issues that we're going to have to deal with as we plan for next year.
Amanda wants to respond as well, and then I'll ask Claire and Gemma if there are the other items that haven't been covered, if you just deal with briefly. Thank you.
So just a bit, to answer both Jeffs a bit. This Jeff, the bit about, you know, I'm sure Chorley and South Ribble's experience is no different from any board I've ever sat in where people are constantly flagging up the issue of stroke. But I think we've got to give some credit for the work around the continuous improvement, because if you look at the table for the National Sentinel audit results from a year ago to the most recent set of results, there is undoubtedly significant improvement, not in every bit of the patch for every aspect, but overall we've gone from a red and a whole load of ambers to, you know, 3 greens and some shades of amber. So that we've got to acknowledge that work. Nevertheless, the transformation in the programme is equally important, and we do need to do those things. Jeff, you're absolutely right. Smoking should be in. That's almost a given.
Yeah.
In, you know, as part of our secondary prevention of CGD and management of hypertension and AF and everything it is. You're right, it should be in. When we're looking at hyperacute, that is a relatively small part of the entirety of a stroke pathway. We cannot possibly have them everywhere. If we did, they wouldn't be any good, and we couldn't staff them. And it's also reasonable to say that it will be difficult for every member of the population, all 1.7 million, to benefit equally from something that we can only put in a very small number of places. But actually, everybody will benefit from the proposals. It's just that if you happen to live next door to a hyperacute unit, you will get to one quicker. But everybody's care options will be improved by this proposal, recognising that some people will still live further away than others. But actually, screaming on behalf of some of the population of the more rural bits of Morecambe Bay and South Lakes, we should be screaming about the fact that something that might have a much bigger output on their long-term recovery and return to living independently, we're not delivering at all any aspect of. And that is likely to be a much more impact on that rural population, and we should be really addressing that, I would argue. So the, you know, whatever's happening in South Lakes and the bits of the patch that are red for every aspect of the reablement and community rehab would, I think, be of much more benefit to that population if we got it right.
Okay, Gemma and Claire, if you just round up for us, please.
So Amanda's very helpfully covered a lot of what I was going to say. And I would by no means say that the improvement is right across the board, and we are not anywhere near where we need to be, but we are absolutely on the way. And I think the progress that we've made, which is around a joined-up approach across Lancs and South Cumbria, rather than individual hospital trusts looking after their own individual sites, I think is a big step forward. But I think the SNAP scores absolutely demonstrate that where we've made massive improvements, you know, for a trust that's got an A score, for those of you who don't know, it means that they actually get a best practice tariff, which does have other implications around the finance, but as Gary said, we'll be addressing that on the 15th of November, at least starting to. But we have been having discussions, and the finance subgroup of the programme board has been working on that for a number of months. In terms of, so your response to your question about the HASU and Cumbria, it's really useful to hear about what's going on up there. As Amanda said, we are not looking at implementing hyperacute stroke care, but certainly from a clinical perspective, we need to be building on what we do from an acute perspective, because that hyperacute bit of the pathway is very small. So we will be implementing hyperacute stroke units, but you know, from a staffing and workforce perspective, that's the biggest challenge that we have. And it would be really interesting to hear about that building health.
The messages to the community.
Yes, exactly. Yeah, no, I get that. And in terms of Cumbria, we met with the Morecambe Bay Trust Executive this morning, and one of the commissioners who's been very involved in our work, and we started to talk through how we are going to make it very clear for the residents of that part of the patch what we are going to do to ensure that they get the best possible outcomes. But as Amanda said, at the moment, they're not getting the best possible outcomes because of the pathway. And in terms of smoking, we don't have the control over the prevention and population health agenda. It's now within the whole programme because it's an end-to-end pathway. But I'll absolutely sure that that message gets back in terms of that being in the policy. Have I covered all of the points?
That's pretty good. Yeah. Andrew just wants to make one final brief comment and we'll move on.
Sometimes papers like this are helpful because they provide quite a detailed stock take. And from a perspective of the Joint Committee, that was partly predicated on helping to understand where commissioning needs to come together to secure certain outcomes. But one of the other benefits is that the paper can be used in other places. And I know that Gemma is sharing this paper tomorrow with the provider leaders. And I wondered if you would take a view that you've already expressed yourself, which is the expectation from the Joint Committee that you need to work together more effectively to resolve some of the issues about service delivery. Yeah. This isn't going to come down just to commissioning investment. Where those gaps exist and where the models need more collaboration, the providers need to do that as well. So if you would convey that, it is the sentiment you've expressed yourself that is in the paper.
Yeah, absolutely.
Okay, so are we happy to accept that report? Thank you. We're on to item 9. Mark.
Thanks, Phil. This is a report for information about the special educational needs and disabilities services that are provided across the county of Lancashire. You may remember that there was a review of these services back in November of 2017 where the outcomes were far from good, and we were put through a process of basically sorting it out. What we had to submit at that point in time was a written statement of action around what we would do to improve the services. We're now nearly a year into that process. We've been through 2 reviews by the regulators, so we have 2 regulators who are looking at this for us. It's the Department for Education and NHS England, where we are really scrutinising on what we've been doing. It's important to say that this initially is a response to the issues that were raised from the review last year. So we are progressing with the actions in the written statement of action. But the important thing is that this is the way that these services and the way that we will work in the future. So it's not just a tick box exercise to carry on as was done before. So what we've got here is a report which summarises where we're up to today. There are 5 areas that it touches on, some of which have progressed, well, they've all progressed okay, but there's some areas that need to, we can never do enough of, if you know what I mean. So I'll briefly talk to you about the strategy side of things. So the important thing that we couldn't do with SEND was to disappear as a group of managers and the like across the county and the CCGs and just sort this out. It was really important that it was done in partnership with young people and with their carers, and that has been absolutely fundamental to everything that we've done. And as part of that, we needed to come up, we started off with an interim partnership board, and it's now been developed into a full partnership board which has a number of patients and carers who are members of that board. So they don't just attend meetings and observe and the like, they are members of that board, which is really quite refreshing. One of the issues has been the commissioning of services, and Hilary Fordham has done a tremendous amount of work with this. Basically, I think now we have one commissioning function across
health and the local government in this particular area. We had a number of issues that were identified in the report. One of them was around ASD, so I think autism, particular issue in North Lancashire, where now a service has been put in place. And 135 children and young people have been moved off the assessment waiting list. That's in just a few months, so that's a real positive move. Engagement is absolutely of crucial importance with this. We've done a lot of engagement with schools, with patients, with carers and so on and so forth over a number of times. A number of events have been held with schools. We've worked with school heads. And out of this, as an example, we have got 44 carers who want to be involved in this programme right across. So this isn't a tokenistic involvement. This is an actual real involvement in what we're trying to do across Lancashire. So obviously we've accepted that, and they are involved in that. Now, engagement is going okay. We have a lot of young people involved in it. We have the Power Group, which has produced some really great videos and told some really powerful stories about people with these sorts of disabilities. I think it's something that we will continue to need to do more on. So as an example, one of the things that we're working on just now is the local offer website. So clearly, it's important for families to be able to access some support, and for that support to be consistent and to get a good message to lead them through all the challenges that they face. There is a local offer website, apparently, which is available for Lancashire, which isn't timely, it's not easily accessible, and so on and so forth. So we're going through a process now through the engagement work stream to develop a new website. So we've had 16 regional events attended by 190 parents and carers around what this service should offer. So that's an example of how we were working with engagement. We have a number of practitioners who've been involved, 129 practitioners, 600 patient carers, 368 children and young people completed particular surveys that we've asked for. 285 educators have attended 18 partnership events across the county. That's what we need to be doing consistently throughout this process. So recently we had an assessment visit, I think it was at the beginning of October, and we assessed engagement as amber. So that doesn't mean that we're not doing things with it. There is more to do, and we can never not do enough engagement. I think the other issue that's been particularly important, and we're really moving, I think, to some of the nitty-gritty of these areas, is the appointment of designated clinical officers. So the designated clinical officers will have a really key role in assessing the quality of health and education care plans that exist for these young people, that to ensure that they are of the right quality, and that they're of a consistent quality across the county. So that's something that we're moving into now as well. The other one, again, I suppose, which is, for me, is really the crux of it, is about improving outcomes for these people with SEND issues. And I guess the issue for me is that what we are doing now is working to improve the outcomes for these people, to get them a good start in life and make sure that they are supported in that, which I don't think has been done to the right level as has happened previously. So we're working with developing these enhanced health and care plans, but we're also working with schools to try and reduce the number of exclusions from mainstream education. That is really key. We need to have these young people involved in mainstream education and reduce the number of exclusions. So with that requires a lot of work with schools, with school governors and so on and so forth. So we've got the designated clinical officers, enhanced health care plans. We are now moving into working with schools to improve the life opportunities that these people have by trying to ensure as much as possible that they are in mainstream education. So there's a lot going on. We're under a lot of scrutiny with it, quite rightly. I think the final scrutiny visit that we've got is in December, but that doesn't mean that we let off with this in any way, shape or form. It's really great that we've got parents and young people involved with this. I have to say that from a personal point of view, it's been one of the more refreshing things I've been involved with for quite a while. I think as well what I would like to add is that during this period of time, there's been an interim Director of Education and Children's Services in place in the county, a chap called John Redman, who's led this process. I think I would like to commend the approach that John has used with this. He's got just the right sort of personality and he's set just the right tone with this. As has Sian Rees, who's the improvement lead, who's pulled all the information together for the regulators. I'll leave it at there. Thanks, Phil.
Thanks, Mark. Any questions or comments of Mark on that? Dominic?
Yeah, I just really want to commend this piece of work from a public health perspective. This is one of the areas that I think is probably most critical for the health and well-being of vulnerable young people to redress inequalities in life chances. I mean, one of the things we know from a public health perspective is if you think of the criminal justice system, between 40 and 60% of the young people in the criminal justice system have a probably undiagnosed learning difficulty or autism spectrum disorder. There is some diagnosis. This will make a big difference to the risks of that cohort going into the criminal justice system. And one of my comments really is when we're costing the outcomes, we're perhaps missing the whole system economic impact of some of our policies, and this is a really good example. You know, so in other words, resourcing this by improving this service in the way described here will have a big impact not just on school exclusions and kids going into pupil referral units, but on the criminal justice system eventually. The other thing I just want to commend is one of the problems many people find in this area is they take their child into the GP and eventually go through a system and are told the child doesn't meet the diagnostic criteria, even though the child has behavioural problems. And this policy is committed to support at all stages, the idea being regardless of a diagnosis, the child and family should has a need and therefore requires support to address this, and this will be provided. I think that's critical as well, because it's saying, you know, if you're bringing a child with an issue, even if it's slightly outside diagnostic criteria, we're going to try and help you fix that, and I think that's critical. So I think this is one of the best pieces of work I think we've done all year, and it particularly is going to reduce inequalities.
Thanks, Dominic. Is there anybody else? Sue?
Yes, we've already had described to us several engagement approaches that are taking place, but I would like to put an offer on the table from the 4 health watches across Lancashire, South Cumbria to get involved with supporting this to an even greater degree. We're very active in all the communities, and it seems like it's a very appropriate piece of work we should be supporting.
Amanda?
So I am sure that the programme would welcome that offer. I think the other thing to say is the poor inspection outcome and the consequent pressure to deliver has been on the Lancashire County bit of the patch. But actually the benefit of doing this and including everybody and applying what's been learnt from this approach throughout the patch would be huge. And so it's really important that we actually do that both in our engagement but or in our implementation of the outcomes of some of this.
Thank you. I had no other indication, so we're happy to accept that report. Thank you. We move on to item 10, commissioning development. Andrew.
Chair, thank you. So again, a brief introduction to a straightforward paper for information today. Members will remember back in June, we received recommendations for continued work in relation to commissioning development, and they were presented by a number of work streams. Joint Committee approved those, but asked for a greater formality to the approach being taken around ongoing implementation. So this paper really simply just quickly summarises the approaches that we have continued to take in the light of your discussion back in June. So 2 or 3 things just to emphasise. The first is that we have a more formal executive oversight group governing that work, which contains representation from each CCG, from the CSU and from NHS England. It will be that group that gives either consent or not consent to bring proposals back to the Joint Committee. So that group has been in place for a number of months and is holding the programme as you requested. Discussions continue in those work streams that we previously mentioned, to ask colleagues to give us their best advice about how we organise our work around commissioning. There is more to do in relation to that. I'm not going to pretend that. There's more to do in some of the work streams. There's more to do in relation to our work between health and local government. But that work is progressing to the point where each work stream has been asked to develop what we've called a portfolio. So effectively summarising what their work is, what their recommendations are, what their priorities are. You remember you were quite insistent back in June that we needed to know exactly what the priorities were, what their governance is, what their clinical leadership model is, and I suppose latterly a sense that we need to be clear about how we're going to offer assurance back to the host participating organisations, particularly where we've decided that we're going to do work at a collective level. We need to create some of the mechanisms that 1 or 2 of you have pointed to today about how we get that loop of feedback or monitoring or outcome. So they're paying some attention to that at this stage. I am also conscious that the commissioning development work is not just happening at a Lancs and South Cumbria level, that for a number of colleagues around the table, there's a lot of work going on to bring together commissioning teams that have previously been working in separate CCGs. So that is playing out. And also, we're continuing to think about how we work at neighbourhood levels, because that's where some of the best work has been done in the last 3 years. So that work is also proceeding. The discussions that we've had have led us to believe that the thinking around mental health and the thinking around our out-of-hospital commissioning arrangements is going to come in front of you earlier than the other work streams. They're quite different in the way that they're going to work through, but those are the 2 areas that are going to come to you first. So that is what we're preparing, and that was, again, one of the reasons for this paper. I think we remain very conscious that we're talking here about change for individuals and culture change in its widest sense. So we've, again, been paying some attention to issues around helping people frame what they need to get organised, to agree with each other, so that this does not become a disruptive period of change. But it is a period of change. So again, I wanted to give you some assurance that that is in our view at this point in time. So this was very much for information, Chair. I'm happy to take any questions if you wish.
Okay, are there any questions? Mary.
I'm very supportive of this piece of work because it continues the commissioning development framework that we signed off some time ago. I suppose my question is really about when do we see the results coming through? I note the timetable for bringing back the particular areas around mental health and out of hospital care, but I think I'm sort of pushing to see what impact there will be on the commissioning process. When will we be commissioning more effectively in line with our framework? When will we be able to deliver better outcomes as a result? Because ultimately, I think this has been the purpose of doing all of this. So if you could give us a sense of when we're getting into the nitty-gritty of making this real on the ground, would be quite useful, Andrew.
Thank you, Mary. So certainly if we take mental health as an example, we're hoping that through our workshop process next month, we're able to agree the proposals that have been developed. And then that could be, we can use the period January to March to get as much of the operational arrangements in place as possible. Let's not forget that there are already a number of really critical issues in mental health commissioning that need a collective response. So to some extent, there is some implementation already. The other work streams that I haven't named, again, the expectation is that they would go through this assurance group, the commissioning oversight group in January, with a view to then coming to the joint committee in February. So I'm trying to get to a point, I feel, where we could say confidently from April we've made a number of shifts in the system. And I think that's the expectation that the work stream leads have themselves.
Okay. Jeff.
Andrew, with regard to the work streams, and particularly the outer hospital one, and maybe some of the others, what's your thinking around involvement of primary care in the thinking as opposed to primary care as commissioner?
We're pleased to have the work stream lead for the out-of-hospital stream, Peter, so I'll let him take that one.
So yeah, just to give you a bit of confidence and assurance that primary care colleagues, both primary carers, commissioners and providers, have been involved in the development of the recommendations from day one. If anything, we've had so many primary care colleagues around the tables at times, it's actually been quite difficult to manage them all. We have another session with us. We've got another session next week, and again, we've got a number of colleagues, LMC and others around the table for that. Absolutely.
Yeah. Okay, that's great. Thank you.
Okay, Dominic.
Chair, what I'd like to do is bring in any other business item to this question to Andrew.
Okay.
That's all right.
Slick.
Andrew, the NHS 10-year plan is going to come out soon, end of November or early December. One of the key asks it's going to make is that CCGs, in particular as commissioners, develop a population health system approach to what they commission. In other words, they're there not just to commission what services we need once somebody has a diagnosis, but what services and interventions we might want to commission to make a difference to needing that diagnosis in the first place. And it goes back in a way to the stroke discussion. So, a colleague of mine in Sheffield, if we take something like weight control, a colleague of mine in Sheffield has done a piece of calculation on where the money is going to deal with overweight and obesity. And one of the arguments he's making is that 60% of his population is either overweight or obese. He can see through the tiered services jointly commissioned with CCGs about 700, 800 people. But he has over 300,000 people in that population who would be eligible. And so he's estimating that with the current model, it would take 240 years to get to zero prevalence for obesity in the population. And of course the answer to that then is the system, the NHS system, can't treat its way out of it. Not just in Sheffield, I mean everywhere. And so the commissioning system needs to look at what it commissions in a very different way for those sorts of things, areas, mental health, type 2 diabetes, obesity, where just commissioning more treatment services is just not going to do it, or at least not going to do it in about 10 generations. And that 240 years is just to deal with the current population who are obese, but of course you're recruiting into that cohort every 10 years. So it's just a question about how then, post-NHS 10-year plan, if we're commissioning outcomes, not activity, how do you think that will change where the NHS invests its money, what interventions we commission, and perhaps who we commission them with?
Amanda's going to have a go at this.
I'm going to pick that up and just quickly tell you how I can't answer it. So, there's a few things. As you say, we're expecting the 10-year plan. What the 10-year plan is not going to do is go into the detail of what outcomes we're commissioning for, but actually is going to very much go into the two fundamental issues there, which is how do we focus on on prevention where we know it is effective in order to manage demand, because that's the only way we will manage demand. And the other is, how do we focus our efforts not only on improving health but on reducing health inequality. So if that's the issue in Sheffield, where there's loads of hills and a slightly more affluent population, imagine Blackpool with all its takeaways and no hills at all. So, you know, what are we doing that makes the most deprived populations or disadvantaged groups most able to benefit from the interventions we make, rather than just people in this room getting healthier and healthier and healthier. So both of those things very much feature in the 10-year plan, or will do. And I would suggest that the other aspect, the population health management, we are one of a small number of first wave ICSs that has been asked to be an exemplar area for that. So I would suggest two things. One, this group very much will need a session either December or January, depending on timing, to talk through the implications for the way we work of the 10-year plan and what it says. And the other thing I would suggest is that we ask the people focusing on population health management to come back and talk through the implications that work has for how we work, particularly in our ICPs. And it's much wider than just smoking, alcohol, obesity, health inequality, secondary prevention. It's very much about how we use robust data to focus our interventions, both from a prevention and treatment point of view. So I think both of those are big, meaty topics for us to bring back.
Okay, any other questions or comments on that? Or on the any other business? Right, thanks very much. So we now come to the point where we have the opportunity for members of the public who might want to ask a question. Would anybody like to ask a question? Yes, sir.
I think I'm going to have to ask a question. It's not strictly speaking agenda for the meeting, but it's been unclear to me for quite some time what the governance arrangements are going to be for the integrated care system and how that will relate to the joint CCGs committee. And I was wondering if you could at least point me in some direction where I can find this information in a relatively easy to understand form.
Yes, I think you've had an earlier conversation with Andrew, and he's undertaken to speak to you separately after the meeting to explain that to you, but also signpost you to any further information that you want, if that's acceptable.
That's fine.
Thank you very much. Are there any other questions from members of the public? No? Okay, well, finally, the date of the next public meeting of the Joint Committee is the Thursday the 10th of January, 1 till 3, as usual, at a location to be determined. Thanks very much for your time.